We'll just give it another minute, then we'll get started on this really great webinar. We've already got hundreds of people in, so just give it another minute. Look at that. Look at all these posts.
From all over
Everyone
the
from all over
world.
the world. All over the world. This is a great thing. All right. Well, let's at least get started on introductions and things of that nature. People are still coming in, but hello, everybody. My name is Andrew Spiegel. I am the current board chair of the World Patients Alliance, one of the co-founders, and it's really my pleasure to welcome you to our next monthly webinar. And this one is really interesting for me. I've had surgery. Everybody has had surgery at some point in their life. And, I was told nothing after 6 p.m., nothing after 8 p.m. I don't remember the exact thing I was told. It was a long time ago, but apparently things have evolved, and we're going to learn all about the importance and when to fast before going in for an operation. And of course, this affects all of us and all of the disease areas that we work in, because surgery is often part of our disease control plan. But we're all going to have surgery at some point for the most part. Uh, so let's get into a little introduction to the World Patients Alliance for the new people. We have a lot of new members who have joined in the last month or two. The first thing I want to tell you is that we do have an AI translation service called Wordly. And in the chat, you probably have to go all the way back up to the top of the chat, but in the chat, you'll see a link for Wordly. You click on the link, you select your language, you enter your name, and then you click attend, and then you'll listen and watch everything in more than 50 languages. So you'll choose your own language and you'll be able to hear and see everything in your own language. So just click on that link in the chat. And just another slide or two about us for the new people. We are the world's largest umbrella organization working across all disease areas. We want to make sure that the patient is in the center of all discussions, and we do work across all diseases to make sure that the patient is at the center of all healthcare decision making, and that patients have an active role to play in their own planning and provision and monitoring of their own healthcare services. Next slide. We serve more than 775 member organizations now. The vast majority of them are NGO patient organizations, disease organizations, and a couple associate members. We're in 142 countries, so we continue to grow and grow each month, and we have dozens of outstanding applications right now that the membership committee is reviewing. So we appreciate all of our members and all of you joining our webinars each month. Let's go to the next slide. And I'm going to introduce you to the world famous Helen Haskell, who is very involved with the World Patients Alliance, and she's the chair of our Patient Safety and Quality Committee, president of the U.S. nonprofit patient organization Mothers Against Medical Errors. She's an Institute for Healthcare Improvement, senior fellow chair of the Patient Engagement Committee, of the Committee to Improve Diagnosis in Medicine, and a board member of the Patient Safety Action Network, very involved in the WHO and their patient safety program. All this other stuff you see here on the slide. I don't want to spend the whole webinar talking about our famous Helen. I'll turn it over because she's going to moderate today and bring us all this valuable information. So Helen, thanks very much.
Oh, great. Well, thank you, Andrew, for that very thorough introduction. Um, and I want to welcome everybody to our webinar on this very important topic. Perioperative fasting is not something most of us think about very often, but it's something that underlies every surgical patient's well-being, and it's time we all began thinking about the evidence versus the customs. So we're fortunate today to have one of the world's leading experts on preoperative fasting who's going to talk to us about what the guidelines on fasting really say and how they ought to be approached. This is our agenda. We're going to have our keynote address from Anne Rugenberg, and that I will say a few remarks about our membership's experience of preoperative fasting. Then we'll have a panel discussion with a number of experts and closing remarks by Mirko Chikalova from the European Patient Safety Foundation. Next slide, please. So I'm honored to introduce Dr. Anne Rugeberg, who's a senior consultant in anesthesiology at the Helios Klinikum Emil von Behring in Berlin. She also holds a Master of Public Health degree and has played a leading role in advancing international discussions on preoperative fasting practices. That includes, among many other accomplishments, coordinating the development of the recent international multidisciplinary consensus statement on preoperative liquid fasting, which you are about to hear more about. I just want to remind you all that if you have questions that occur to you during the talk, please go ahead and put them into the Q&A at the bottom of your Zoom screen. And they will be relayed to Anne at the end of the presentations. So Dr. Rugeberg, the floor is yours.
Well, thanks a lot for the invitation to this webinar. I hope you all see a green screen.
We do.
That's great. So my name is Anne Rugeberg and I'm from Berlin. I would like to introduce in this webinar you to clear liquid fasting before surgery. In 2019, the World Health Organization announced the first Global Patient Safety Day under the slogan, "Speak up for patient safety. No one should be harmed while receiving health care." Well, we anesthetists care for well over 3 million patients every year. We have a lot of safety protocols. Well, but don't you think we sometimes ignore reality? Consider preoperative fasting. For more than 25 years, patients have been allowed to drink clear liquids up to 2 hours prior to anesthesia induction. For pediatric patients, this interval has been reduced to 1 hour. Unfortunately, the reality is a totally different story. Under this current fasting recommendations, many patients have not had anything to drink for a median of 9 to 14 hours before surgery and procedural sedation. Some say it's not a big deal if patients drink less. Have they ever heard of dehydration? Some even call dehydration the silent epidemic. Dehydration before surgery is a real risk factor for patient safety. Patients who went into surgery dehydrated had a much higher incidence of postoperative complications such as respiratory, renal, cardiovascular, and neurological complications than patients who went into surgery well hydrated. And that this is linked to preoperative liquid fasting was clearly shown in a study at the Charité, Berlin. Patients who hadn't had anything to drink in the last 6 hours before surgery had a more than 10 times higher incidence of postoperative delirium than patients who had something to drink within the last 6 hours before surgery. It is often suggested that educating patients adequately about the 2-hour fasting rule would ensure compliance. The Think Drink initiative took this approach for 16 years. Yet the median duration of liquid fasting remained around 6 hours. A lack of information for either patients or staff could not be identified as a primary cause. Similarly, other research groups failed to reduce liquid fasting durations down to the target range of approximately 2 to 4 hours, despite intensive interventions, including staff training, verbal and written patient education, poster campaigns, and providing beverages. One might then propose that OR management could coordinate surgical scheduling more efficiently. However, in practicality, it is often more challenging due to the inherent fluctuations of the schedules during the day of surgery. Procedures cancellations occur in up to 16% of cases, overbooking in up to 13%, and overruns of preceding procedures in nearly 19%. Logistical factors such as patient non-availability, staff issues, or missing instrument account for a further 21%. An international survey of over 900 anesthetists found that more than half did not routinely advise their patients to consume liquids up to 2 or 3 hours before surgery, citing the lack of a system capable of safely implementing such a recommendation and the unpredictability of the surgical schedule. Examining the fasting intervals actually recommended in clinical practice revealed considerable variations. Anesthetists recommended periods of 2 to 15 hours, while surgeons provided similar guidance. Administrative and reception staff, when consulted by patients who had not fully understood their medical consultation, recommended intervals of 2 to 26 hours. Only internet resources consistently provided the precise 2-hour guidance. Furthermore, if a patient who had recently consumed liquids is called to the operation room ahead of schedule and the institution decides to wait for the fasting criteria to be met, the operating room is left unused. This compromises the care of patients scheduled later in the day, as time limitations may cause their procedures to be cancelled. This is the main reason why the nothing after midnight instruction remains so widely practiced. A study examining over 4,700 hospital admissions identified more than 3,600 Neal per mouse orders, affecting almost half of the patients. In the previously cited Think Drink study, nursing staff reported that it was difficult to reliably implement the 2-hour fasting rule due to unpredictable surgical scheduling and competing clinical responsibilities. It was only when a drink until call protocol was introduced that median liquid fasting times were successfully reduced to 2 hours through even this required ongoing follow-up. Then should we simply allow patients to drink until called to the OR? Surely you are not serious. Have you not heard of pulmonary aspiration? Aspiration, a bit of history and how we learn to fear it. Let us see how it all began. When anesthesia was in its infancy in the mid-19th century, preoperative fasting was recommended to minimize the discomfort of nausea and vomiting. In 1883, the British surgeon Sir Joseph Lister published simple, practical guidelines for fasting and was the first to distinguish between solids and clear liquids and recommended to give a cup of tea or beef tea 2 hours before surgery. As several hours of preoperative fasting aggravates existing states of exhaustion, tea with red wine or cognac up to 45 minutes before introduction of anesthesia was recommended in the beginning of the 20th century, especially for alcoholics. This procedure changed dramatically in 1946. So obstetrician Mendelssohn introduced the Neal per mouse from midnight rule, applying to both solids and liquids. Unfortunately, the Neal by mouse rule still dominates anesthesiology today. He retrospectively described 66 cases of aspiration of gastric contents during anesthesia in over 44,000 obstetric patients. There were no deaths among the 40 patients who aspirated fluids. They developed asthma-like symptoms but soon subsided. 5 patients aspirated solid matter, 2 of them died from complete airway obstruction caused by the aspirated food. But aspiration is a serious concern for anesthetists because it implies causation. If a patient drinks and they aspirates, the clinician is held accountable. This had led to the standard practice of Neal per os from midnight well beyond half a century. At the turn of the millennium, evidence emerged showing that compared to more than 4 hours, a liquid fasting interval of 2 to 4 hours had no effect on gastric volume. Guideline recommendations for clear liquids were therefore revised to a minimum of 2 hours. Much of the anxiety surrounding this topic is based on the assumption that any gastric content will certainly lead to aspiration and thus aspiration pneumonia. However, this assumption is not supported by available evidence. Aspiration pneumonia is not caused by just one single factor. It develops when a number of factors come together. It needs a sufficient volume of gastric content, delayed or inadequate gastric emptying time, impaired function of the lower esophageal sphincter. The residual gastric content must be regurgitated. A sufficient amount of regurgitated gastric contents must reach the bronchi. The regurgitated gastric content must be harmful to the lungs to cause aspiration pneumonia. Aspiration of clear liquids rarely causes clinical significant lung injury. But aspiration of solid food or in the setting of ileus, however, frequently leads to aspiration pneumonia. Fortunately, aspiration during elective surgery is rare. Retrospective studies report incidence rate ranging from 0.01 to 0.025%. A prospective study of children showed a slightly higher incidence rate. Importantly, allowing patients to drink until called for their procedure does not increase the incidence of aspiration during elective surgery. This is supported by gastric emptying data. Gastric emptying follows an exponential relationship that is proportional to the current intragastric volume. When subjects ingested 500 ml of water, their stomachs were empty within 10 minutes. When 600 ml of carbohydrate-containing drink was consumed, half of the volume left the stomach within 10 minutes, with the stomach becoming empty within approximately 20 minutes. Even when subjects consumed 150 ml of clear liquids every 20 minutes, totaling 900 ml within 1 hour, equivalent in caloric content to a small breakfast, exponential gastric emptying was maintained and gastric volume remained low. In line with these physiological data points, patients who were allowed to drink until they were called for their procedure did not have a gastric residual volume as demonstrated by a study of gastroscopy patients. The only patient with a markedly high volume had fasted for clear liquids for over 10 hours. In fact, most aspiration events are a result of failure to recognize the risk factors for aspiration and to adjust the anesthetic technique accordingly. Therefore, we ran a risk-benefit assessment. Historically, it was assumed that consuming clear liquids directly increases the risk of pulmonary aspiration. However, this must be weighed against the well-established complications of prolonged liquid fasting, such as thirst, delirium, acute kidney injury, each of which represents a significant patient safety concern. And what about the guidelines? In February 2026, an international multidisciplinary consensus statement on preoperative fasting was published. This statement was developed based on a systematic literature review, a risk of bias assessment, a grade-based evaluation of the available evidence, and a three-stage Delphi process. The consensus process involved 68 participants, including experts and non-experts from the field of anesthesiology, surgery, cardiology, gastroenterology, other medical specialties, nursing, patients' representatives, and international organizations, and some of them joined this webinar. Gender representation was balanced, and participants were drawn from 5 continents, predominantly from Europe. The consensus statement largely reaffirms the existing recommendations regarding fasting from solid food and non-clear liquids. Non-clear liquids can be consumed up to 6 hours before surgery. For high-calorie solid foods, a fasting interval exceeding 6 hours may be required. Following surgery, liquid and nutritional intake should be resumed as soon as clinically appropriate. Regarding the clear liquids, the consensus statement reflects a fundamental paradigm shift towards more liberal fasting regimes. Clear liquids include water, tea, coffee with sugar or honey, including a small amount of milk, clear juices, lemonade, clear carbohydrate drinks. It is recommended that healthcare institutions implement protocols designed to minimize excessively prolonged fasting intervals for clear liquids. These protocols may either continue to enforce a 2-hour fasting period while preventing unnecessary prolonged fasting, or implement protocols that allow the emerging practice of clear liquid intake less than 2 hours before the start of anesthesia or sedation. Examples for well-established liberal fasting protocols include the Sip Till Send initiative in the UK and the fasting card concept developed in Germany. And now I would like to introduce you to the fasting card concept, which won the second prize from the European Patient Safety Foundation's award in 2024. Fasting cards are a 3-level color-coded system. Patients with no significant pre-existing conditions or surgical requirements receive a green card and allowed to drink clear liquids until called for surgery. Patients who need an individual approach are given a yellow card, while the red card is for critically ill patients who are not allowed to eat or drink due to pre-existing conditions or surgical requirements. The fasting cards are licensed under the Creative Commons BY-NC-SA license, meaning they can be used and adapted freely for non-commercial purposes by any clinicians. During the preoperative anesthetic consultation, the patient's medical history and the planned surgical procedures are reviewed. For instance, a patient undergoing total hip arthroplasty and classified as AZ2 is given a green card, allowing them to consume clear liquids as well as tea and coffee with honey, sugar, and or small amount of milk until they are called to the operation room. For example, a patient presenting to the emergency department with ileus would be given a red card. By contrast, a patient who had broken their femur after falling while on their way to get coffee is given a yellow card. They are told not to eat as they are due to undergo surgery soon, but they can drink clear liquids until they are called and will be provided with coffee at our facility. A child with a forearm fracture is offered a water ice lolly and a large apple juice prizer. These measures help to reduce the burden of waiting time. Patients who will not undergo treatment or surgery until the following day are given a green card in the emergency department and are permitted to eat and drink. Inpatients are given a laminated card to display on their bedside. Outpatients and pre-admission patients receive a paper flyer to take home. There are 4 additional languages on the back of the cards, which can be customized by each hospital and are available in the languages you see on the right of this chart. With the concept fasting cards, we reduce the median liquid fasting time from 12 to 2.1 hours. Before implementation, almost 70% of patients had not consumed any liquids for over 10 hours. 25 weeks after the introduction of fasting cards, around 80% of patients had consumed liquids within 4 hours before induction of anesthesia. A small number of patients continue to present with prolonged liquid fasting times. However, these are mostly patients who habitually did not consume anything in the morning and for whom the need to drink would have caused additional stress. Patients who were allowed to drink until they were called for the operation room consumed a median of 400 ml on the day of surgery prior to induction of anesthesia. Those with an anesthesia start time before 11 a.m. consumed a median of 250 ml, while those with a start after 11 a.m. consumed a median of 500 ml. Furthermore, patients who are not aware that liquid intake was permitted showed significant higher rates of morning medication adherence than those who were not informed. What began as a small-scale initiative has been adopted by over 150 hospitals across Berlin. And where you see the red 18, that's my hometown. We are particularly pleased to have received second place in both the Patient Safety Award from the German Coalition for Patient Safety and the Butterfly Impact Award from the European Patient Safety Foundation in 2024. Thank you for your attention, and if you are interested in adopting this concept, you are welcome to join us. You will find all relevant information on our website. Thank you for listening.
Thank you, Dr. Rugerberg. That is a tremendous amount of information to take in. I'm looking forward to discussing it further with our audience in the panel discussion. Um, and as I said, please put your questions in the Q&A. You can put them in the chat if you can't find the Q&A, which might be under the 3 dots off to the right on your screen. But I just want to say a few words to sort of give us a snapshot of what this is like for patients. We've had a lot of information about what it's like from about the science behind it, but not from patients. So I'm going to start out with some personal stories actually, because I have a personal interest in this topic. I was part of the Delphi study for the consensus statement that Anne mentioned, and I was very pleased to accept that invitation because my own son, Louis, arrived in the hospital dehydrated many, many years ago. And it was a condition that spiraled out of control because it was never adequately managed postoperatively. And the end result was that the NSAID medication Louis was being given for pain control, ketorolac, became very concentrated in his system, resulting in a perforated ulcer, peritonitis, hemorrhage, and ultimately death at the age of 15. Of course, I can't say for sure that fasting was the cause of his dehydration, but it could not have helped. And while the postoperative management was what turned this problem into a fatal event, the root cause on which it all rested was the initial dehydration, in my mind. And my second case is also in my family, and it had occurred many years before that. But my sister-in-law, Mary, Louis's aunt, one of my close friends, was a type 1 diabetic. She went to the hospital for an eye operation, which was delayed for 6 hours waiting for the doctor to arrive. It's hard to tell from her medical records, which I have, whether Mary had IV support during all those hours of waiting. It's hard to imagine she didn't, but it's not mentioned. In any case, she had been fasting since the night before, probably close to 20 hours altogether. And according to her mother and her boyfriend who were with her, and Mary herself, she was in bad shape by the time she was taken into surgery. What exactly that means, they thought she was going into a coma, a diabetic coma. Postoperatively, her course was very rough and her blood sugar was out of control. She emerged from the hospital 2 weeks later, blind and on dialysis at the age of 33. In this case, the family directly blamed it on the pre-op fasting, which came to over 24 hours, including the operation. But my point is that there are many potential complications with fasting. It involves the entire journey through the hospital system, and the way in which it's undertaken needs to be considered very carefully. So, next slide, please. So these incidents both happened very long ago. And while treatment of diabetic patients may have become more sophisticated, the overall protocols, as you've heard, have shown little change since then. But as Dr. Rugerberg pointed out, most of the global guidelines do recommend liquids until 2 hours before anesthesia. So on the theory that postoperative fasting is a pretty universal experience, we surveyed a convenient sample of our own board and council members to find out their more recent experiences. Our sample was 12 individuals who reported experiences over the past 10 years. They represented all 6 of the WHO global regions and included lower, middle, and high-income countries. Next slide, please. So here are our findings. The majority of the patients from all regions were asked to refrain from eating for 10 hours or more. The exceptions were 3 hospitals in the UK, US, and Uganda, with a 4th UK hospital only requiring a 4-hour fast. 5 patients were asked not to drink for 8 to 10 hours, 5 for 6 hours, and one of them, the same UK hospital, for 4 hours. 10 of 11 reported being told nothing by mouth after midnight. I think the difference in number of hours has to do with when they were asked to report to the hospital, probably. But the 11th case that was not told nothing after midnight was our Progressive London Hospital with the 4-hour fasting requirement. And the 12th, which I have not included in these statistics, was an emergency case that was taken directly to surgery with no preoperative fast. Next slide, please. So we wanted to know what the effects were on the patient. So 4 patients, a third of our little sample, reported no ill effects. 1 reported being very hungry, and 5 reported being thirsty, some extremely so. 1 reported uncontrollable shaking in recovery. There are many potential causes of this reaction, which I don't think is uncommon. It may have nothing to do with the prolonged fast, but one potential cause is hypoglycemia, low blood sugar. And as in my son's case, while the fasting may not have been the cause, it certainly couldn't have helped. So in this case and 2 other cases, that is a fourth of the sample, the surgery was delayed and the fast was prolonged. These delayed patients had more ill effects. And I just want to add that completely aside from this survey, this is a phenomenon I hear about often from patients, especially patients who are already hospitalized, who may have procedures delayed repeatedly, leaving them fasting sometimes for a couple of days. This is something that falls through the cracks. No one appears to be in charge of looking at the nutritional and fasting status of hospitalized patients, at least not in the stories I've heard. And the effects can be severe, especially if the patient is already in a compromised condition. Next slide, please. So that's it for our survey. Next slide, please. I want to now change gears and open up for our panel discussion, where Dr. Rugeberg will be joined by a number of other distinguished experts. I'm going to introduce them briefly. We have their bios here and on the website, where you can find further biographical information. So I'm going to start with Dr. Anne-Marie Camilleri Podesta. She's a board member of the European Society of Anesthesiology and Intensive Care. She's chair of its National Anesthesiologist Societies Committee and president of the Association and Anesthesiologists and Intensivists of Malta. Next slide, please. Okay. Mrs. Doina Carmen Mazilou is a senior lecturer at the Carol de Vila University of Medicine and Pharmacy in Bucharest, Romania. She's vice president of the Order of Nurses, Midwives, and Medical Assistants in Romania and director of the Romanian Center for Nursing Research. Next slide, please. Professor Maria Pilar Astier Peña is permanent professor at the University of Zaragoza in Spain and president-elect of WONCA, the World Organization of Family Doctors. Next slide, please. And last but not least, Jolanta Balinska is a World Patients Alliance board member, a global leader in patient rights and patient safety. She's founder of the Polish Patient Safety Foundation, Director of Development and Social Communication at the City Medical Center in Lodz, and a lecturer at the School for Nurses in Kalisz. So again, the panelists will all be taking questions from the audience. So put your questions into the chat or the Q&A, and we will convey them to the speakers. So if we can, yes, thank you. I would really like to start with Jolanta, who's had a recent personal experience with a family member who was kept fasting for a prolonged period. Jolanta, could you tell us about what happened with your mother who was without liquid for a number of hours before surgery? You unmute, Jolanta.
Sorry. Good afternoon. Thank you for opportunity to share my case, because it is not individual, as we see from a survey presented by Helen. It happens in many countries around the world. So my mother is 86 years old woman, and she's supposed to have a small surgery. We arrived to the hospital in the evening, and she was told not to eat anything after midnight, because she should have this operation, this surgery, early in the morning. So it was okay. In the morning I arrived, because it was in the city hospital. It was my hospital, so I arrived in the morning, and she told me, no, she will have this operation after 2-3 hours. So she still had nothing to drink. But after a few hours, they gave her hydration in intravenous hydration, and still nothing to eat. So her lips were so dry, and she asked many times nurses and doctors to receive any water or juice. It not happens. So in the late afternoon, so it was like many, so 14 hours or 16, she received anything to drink, but the operation was moved to another day. So the next day, before the surgery, she was so angry, so much in panic, she started to scream. She is a very silent woman, but she really started to scream to me, to nurses, and I felt very lost, because I didn't want to make any intervention, because it was my hospital. So I didn't want it that the doctors, physicians, nurses will think I will something special for my mother. I was thinking it should be like this, but I saw her fear and her hunger, because she also didn't receive any normal food. So next day, you can't imagine, but after this surgery, she also received not any food, and the patient who was next to her received a lunch. So she asked her for the lunch, and she ate another patient lunch, and she received something to drink after some hour after this surgery. So I think it was completely disaster. After the whole situation, I asked the anesthesiology department why it happens. So they told me they know the guidelines, and she should have this drink, but the nurses forget about this. So it was a human factor, but I think many patients are in similar situation. So we really need to be careful, and we need to make an education for nurses, but also education for patients, that they claim for their rights. Thank you.
Thank you, Yolanta. I think it's really good to have that detailed explanation of really what can go wrong, and the fact that, again, the whole system is involved. It becomes a cascade. We have a question from audience member from Robinson Rodriguez Herrera, or Rodriguez Herrera Robinson, I guess, asking what has happened to the follow-up of the first global patient safety recommendations by the WHO and PAHO in countries' health systems and policies. They're specifically talking about the safe surgery checklist. So the checklist of safe surgical practices and adverse event management and reporting systems. Are government and health care systems required to provide these periodic reports now? I'm not quite sure. That might be a question for Dr. Camilleri. Do you know about the recommendations for the surgical safety checklist?
Yes. First of all, thank you immensely for the kind invitation. In the WHO safety checklist, actually, we just check, at least, I mean, fasting is not actually one of them. So before we check name, consent, etc. But what nurses check before operation, at least in our hospital, is whether they have fasted for 2 hours, but not whether they have fasted for 12. So this is one of the big issues, you know. So the problem is actually invisible, and this is actually came out in our study. You know, the third study that we just conducted, it's the massive implementation gap. You know, that in more than 5,000 patients in 12 different countries in 46 hospitals, okay, the actual median fasting time was 12 hours. Okay, so while the guideline says 2 hours, tick box, checked, we are not actually measuring, you know, routinely, like we measure blood pressure or pulse oximetry, the actual fasting time. And as long as you have fasted for 2 hours, then you are compliant. And this is a very big problem. We have, the third study actually shows the huge implementation gap, that the 2-hour liquid fasting guideline is not really implementable, and for all the reasons that Dr. Anne Rugerberg mentioned, you know, the surgical schedule variability, we don't know how long a surgery is going to last, communication, you know, if a nurse says one thing, you know, the preoperative assessment says another thing, the anesthesiologist says another thing, the surgeon says another thing, the patient will follow the most restrictive path to be on the safe side. And I think this is part of the problem. So as you rightly said, you know, that education has to go beyond healthcare professionals. So the entire multidisciplinary team needs to be involved, including the patient. I don't know if I've answered the question.
I think that's a very thorough answer, and I appreciate it. I think it's a great answer. I would also, I'd like to get Carmen's perspective as a nurse. As a nurse with many years on the ward, Carmen, have you ever been in a situation where you could see that a patient needed better hydration, a specific patient, that prolonged fasting was making them uncomfortable or anxious or unwell, but the hospital protocol or the guideline didn't allow you to act differently? I mean, how did you experience that moment? What did you do?
Firstly, Helen, I want to thank you kindly for the invitation. I'm honored to be here with distinguished panelists. Thank you for that question, because I think many nurses will recognize in this situation. In my experience, there are moments when we see the patient not as a case at operating list, but a person who is thirsty, anxious, uncomfortable, sometimes weak or confused, and who does not fully understand why they are still not allowed to drink anything. I think already our colleague Jolanda expressed that situation. As nurses, we are very close to the suffering. We are the ones who hear the repeat question, "Can I have just a little water, please?" We are also ones to have explained the rules, reassure the patient, and at the same time respect the medical instruction and hospital protocol, and this can create a real professional tension. One hand, we want to protect the patient and follow safety rules, and on the other hand, we can see that the old nothing after midnight approach may create avoidable discomfort and something real harms. What is left with my professional is believe that the nurses need clear, update, evidence-based protocol. We should not place individual nurses in impossible position of choosing between compassion and compliance. The hospital protocol must make the safe things also the practical and human things. In conclusion, for that question, for me, this topic is not about only about the fasting rules. It's about dignity, communication, teamwork, and giving nurses and the right framework to advocate for patient safety.
Thank you. That's great. We have another question from the audience asking, are there any specific preoperative fasting recommendations or considerations for patients living with autoimmune or chronic conditions? They're specifically asking about skin conditions like vitiligo, who are patients that have to undergo surgical procedures like skin grafting. But there are a number of other conditions as well that have, I think, specific requirements. And I'm wondering if Professor Astier-Pina might want to take that question.
Well, thank you very much for inviting me to participate in this panel discussion that is really relevant. Thank you for the introductions. I think you did a really focused word on liquid fasting before an operation and implementation gap. That was primary care, my perspective from primary care, and the impacts on patients and also the professional and possible barriers to address it. So that's true that we have a complex patients with several chronic conditions at the same time, and some of them, as you were explaining, with different medications. These medications define as well the situation of the patient that make really relevant to address these indicators. I'm not an anesthetist. I have the perspective of family medicine, but regarding our concerns as we accompany the patients and we manage people with multiple conditions, and multiple medication, we address these issues in the best way possible. So particularly considering medications, we talk with the patient with cardiovascular antithrombotic risk regarding the medications like anticoagulants and antiaggregants, and also insulins, and then the fragility of the patients. If they are older adults, frail LD patients, that we need to force them into unnecessary 12 to 16 hours fast leads to, as you mentioned, to severe hypovolemia, directly increasing the risk of severe hypotension. And then those with immunosuppressed treatment, as you mentioned, regarding skin disorders, that patient taking immunosuppressant like some products we use in certain autoimmune diseases regarding skin or regarding osteoarticulation like rheumatoid arthritis or gastroenterological problems like chronic disease. Those living with that time of problems require a strict physiological stability to protect the organs too. So that might lead to specific information to them. And I think the proposal of the cards, it's really important, both for anesthesiologists, surgeons, and family doctors to address patient concerns and managing patient risk regarding facing an operation.
Thank you. Thank you so much. And I have another question from the same respondent asking about low resource settings. What practical strategies can healthcare providers implement to improve patient education and adherence to safe preoperative guidelines, especially in vulnerable patient communities? I'm just going to throw that open to any of you who are working globally or internationally who has suggestions for how to handle this in low resource settings. Anne, you might be the expert on this.
It's 2 times Anne.
Yeah.
2 times Anne. Well, I think either one of you might be actually, but let's ask you.
Annemarie, you wanted to say something first.
No, I was going to say that obviously drinking water is much cheaper than, putting an IVI in. For the great majority of patients especially undergoing elective surgery, it is safe to continue drinking clear liquids because, as Anne Rugeberg showed, clear liquids empty from the stomach incredibly quickly, half a liter in 10 minutes. I think this is a very important take-home message. And all the effects of not drinking and being dehydrated, apart from the very important patient-reported outcomes, like thirst, anxiety, as we've heard from someone's relative, much more serious things like delirium, acute kidney injury, respiratory complications. Let's start encouraging patients to keep on drinking until they're called to the operating theater. From the time they're called to the operating theater to the time they're anesthetized, time passes. It's invariably more than 10-15 minutes. And it's a small subset of patients who have an increased risk of aspiration. In elective patients, very few. We worry about ileus and we worry about patients with known gastric problems, with gastric emptying. And again, it is very easy to drink water and clear liquids, and it doesn't cost anything. It's much more costly to set up an infusion. So this is what I would say for low resource settings especially. And
Yes.
in the summer months, I'll just end, we have all these heat waves. It is so important to keep on hydrated and not to have, when we give our anesthetic drugs, we get a sudden collapse in the cardiovascular system. So this is also another important point. Sorry.
And I think there should be no difference between different countries around the world. Patients are all the same, and they have all the same diseases and things and procedures and things like that. And for most conditions, it is safe to drink, because also patients with having gastroparesis or taking GLP-1 receptor agonists, they have a delayed gastric emptying for solids, but not for clear liquids. So you can really let every patient drink. And the guidelines, that is a main problem. The anesthesiological societies still hold on the 2-hour rule, because they say, well, you just have to implement this, and then it's no problem. And we say, great, 2 hours is really great, 2 to 4 hours, everything is great. But everything what goes beyond that is a real burden for the patients. And nobody was able to implement this, except if you say, okay, I accept if that patients drink less than 2 hours. And we have to change this. And this is one reason for this webinar and for what we are doing, that we try to put some pressure, like a grassroots activism, to the anesthesiological societies to move on in regard to our patient safety. And the other thing is the aspiration risk, and there is no increase in aspiration risk if patients drink clear liquids.
Thank you, Anne. That's very helpful. Does anybody want to add to that? If not, Anne, I wanted to continue with you for a moment and ask, what are some ways that people, on the front lines, patients, nurses, anesthesiologists, can speak up and advocate for drinking being allowed up to 2 hours or less before surgery? What are the barriers that they each face, and how can they address them?
The patients.
Well, patients, nurses, and anesthesiologists, one at a time, but start with patients.
Okay. If you're a patient, just go to the doctor and ask until what time you are allowed to drink clear liquids. And if they say midnight, then ask them, you heard something about the 2-hour rule from the guideline recommendations. And wait what they say. If they say 2 hours before surgery, you can ask them how you can find out when surgery will start, because that is the main problem, as we saw. And if they say, well, you can drink until you're called for surgery, you are lucky, but please go to the toilet before you enter the operation theater. But you might have a problem with too much fluid on the other side. And if you're an anesthesiologist and you think, well, it's very good what we are doing, and your head of department has to be convinced, you can just say what Anna Camarelli said. Go and say, fasting times are very long worldwide. I would like to know how it is in our hospital. And you have to ask the right question. If you ask one dear patient, when did you have last time something to drink? They might say, oh, it's just 2 hours ago, because they took 1 or 2 sips of water to take their morning medication. So you have to ask, when did you really have something to drink? Not only 1 or 2 sips, but something like half of a glass or so. And you will be astonished how long this was. And if you are a nurse and you want to convince an anesthesiologist, you can tell them that you joined this webinar and that you would like to shorten fasting times in your clinic because patients are harmed from prolonged fasting. And what can you do stepwise? You can do things like tell the patients that they can drink until leave home to go to the hospital. And then you measure fasting times again. And then you ask patients to drink until they arrive at the hospital. And then you measure fasting times again. And then you can decide, okay, fasting times are sufficiently short, it's okay. And if they're still prolonged, you can take things like drink until call. And the SIP2Send initiative in the UK and in Australia, they allow 1 glass of water for each hour. This is something what doesn't work in Germany, because Germans always have to control everything. And if a patient, if nobody controlled, if it was just 1 glass of water, they say, well, nobody controlled it, I won't start with anesthesia. So we said we don't have any amount of liquids what patients can drink, and we allow to drink until they are called for surgery. Sometimes it's 20 minutes, sometimes it's 2 hours, whatever. And we have these fasting cards because we say you can't put it to every patient. You have to put it decided for each patient depending on their diseases, on their procedure. And there was last week a nice study was published by Marie Marsman, who published 56,000 patients who were allowed to drink, and they came to the conclusion that there is a slightly higher risk in patients who drink for aspiration. But if you go into all these patients, you see 40% of patients were emergency patients, and all 12 patients who had an aspiration pneumonia had other reasons. They aspirated solids, they had an ileus, they had an obstructive esophagus cancer, they had gastric cancer, they had a liquid fasting time for longer than 2 hours, and all these things. So I think we are all waiting, or the anesthesiological societies are waiting for big studies who show it is safe, but then we need something around 300,000 patients in such a study. This is really, really difficult. So have to go into real life data and see why patients aspirate or not. And I'm running a study at our hospital too, and we have from 50,000 patients, only 1 aspiration pneumonia, and that was a patient who had sedation and who had to be resuscitated because his heart went out of control. So that was the reason for this aspiration.
Well, thank you.
Helen, can I say something to Dr. Anna?
Yes, please. Anybody?
I think so. I heard first time about the idea in Madrid during a conference, and I just told to my to WPA it is an excellent idea. What I think from patient perspective is patient doesn't know about their rights. You know, everywhere on the wall in the hospital, they are patient rights, patient duty. priority. But I think we need to promote this fasting time, these different cards, yellow, green, red, on the walls, on the platforms, on any media, so in social media, because if patient will be aware, they know how to ask the doctor, how to ask the nurse. Even not every nurse knows the all procedures or guidelines, and from somebody told, nurse from Romania mentioned, that is the empathy, dignity. But I think if the patients will have the power, the information, if the nurse know exactly about the guidelines, then the communication even with the doctors, anesthesiologists, surgeons will improve very much faster. So this is my opinion. We need to promote this idea about liquids 2 hours before the surgery, and then it will help to all interested parties. Thank you.
Yes, may I say something? Because one problem is that we don't have a guideline recommendation for this. Because the anesthesiology societies are in charge for guideline recommendations and they don't move. So our consensus statement was worldwide, and worldwide we don't have an anesthesiological society like the ESAIC or the ASA or something like that. Promoting a guideline recommendation is not what we are doing. We are doing to promote something what acts against the actual guidelines, but actual guidelines are outdated. They are 15 years old in Germany or in Europe. In America, it's not, but they are very conservative for everything. So we can't promote guideline recommendations which doesn't exist. We can try to promote the 2-hour rule and to solve the problem why it is not met. But the fasting cards project, this is out of guideline. This is just a consensus statement who promotes something like that. And then there is something else. It was here too in the chat. For many patients, it is very, very important to drink not only water. They don't like water. It is very important to drink things that have sugar, are sweetened, mainly for patients on SGLT2 receptor antagonists. Fasting for carbohydrates should be lower than 12 hours. And for many patients, it's very important to drink coffee, because if you're used to caffeine and you don't have it, you will get a headache during the surgery and after the surgery. And the more coffee you drink, the more headache you will have. There are very good studies. And most patients, or in Germany, it's 2/3, and who drink milk only, coffee only with milk. And in the UK, it's 2/3 of patients who drink tea only with milk. So allow them a small amount of milk. This was already recommended in the 2011 guideline by the ESAIC, and doesn't have any effect on gastric emptying. But this was really one of the big threats we saw. We just got 2 correspondences for our consensus statement, and they both said, well, milk, what milk? Any milk, milk, plant milk, what degree of fat or whatsoever. You can take any milk, just a small amount, 1/5, it's no problem. And your patients really need it. And if I may have an example, if you have an old patient with dementia, he cannot read the clock, but he knows at 9 o'clock in the morning, I will get my coffee, and that's the time when it is morning. And if the coffee is missing, he has no orientation in the day. And this is one of the big factors who will have delirium, getting the way to have this patient a delirium. And I think Yolanda's mother, she had a delirium from what she told us. Thank you.
Great, thank you. Maria Pilar.
Oh, thank you very much. It was really wonderful to listen to these tips that Anne said for all of us. I just want to highlight that family doctors, we try to coordinate care and accompany the person along their life course, so addressing their health issues and the safe way possible. And then this is crucial. This is a critical issue for us, because when patients receive contradictory advice regarding the time they need to fast, then the anxiety wins and they default to the strictest, more restrictive rule out of fear, because they think they are going to be wrong if they do not keep with that strictest option. So in many situations, sometimes hospital-centric rules look at the patient for a single morning, but we family doctors, we try to see the patient timeline. And as you said before, a patient may have several surgeries in their life. So we can support the weeks of pre-operation and the days of post-operation recovery, and have the opportunity to do a longitudinal patient education, because we have a long-standing relationship. And of course, with the information you are providing, and we can be in contact, synchronize communication channels, collaborate with our referral hospitals, anesthesia colleagues, and also surgeons to implement these synchronized plain language patient intake sheets, as the cards you were producing. That was great. And share that record, so we all say the same message for the patient, preventing the care fragmentation, because true continuity means the patient never feels handed off to a system that contradicts itself. So as family doctors, our pre-operative preparation isn't just about clearing a patient for surgery, but it's about risk stratification, reducing the anxiety. So we must actively prescribe this liquid clear hydration up to 2 hours, as and Marie said, and to protect organ function, stabilize drug absorption, and preserve metabolic baselines before they step to the hospital, preventing these side events that we have already mentioned: delirium, dehydration, etc. So I think that family doctors can coordinate well with anesthesiology and with the patient engagement we have along our continuity of care, and help to reduce this implementation gap as much as possible.
Great. Yeah, thank you. Family doctors have a big role to play because they know the patient so much better. So I have a sort of double-barreled question here, and it's something I've wondered about myself from, and I apologize if I'm getting this name wrong, but Anushamal B. And they say, why is it important to have oral clear liquids? Why don't the IV preoperative fluids replace it? And then the second part is, what are the suggested clear fluids? What do they include?
Yeah, I would like to answer this question, because it's coming always. If you have a patient who doesn't drink, this patient has just, it's just a lack of water. It's not a lack of electrolytes, which you have in IV fluids. In IV fluids, you have everything you have in your plasma, in your blood. But if you drink, you only have water. And if patients drink less, they dehydrate, and they have something what is called a hyperosmolarity dehydration. That means that outside the cells, the water is missing, but the electrolytes are there. Whereas inside a cell, there's water and electrolytes, and because there is no, they always want to have the same osmolarity inside and outside the cell. Water will go from inside the cell to outside the cell. That means that the cell shrinks, and it doesn't work really good in this condition. And now, if you give IV fluids, you give water with electrolytes. And this means you have hyperosmotic dehydration and afterwards you have a hyperosmotic hyperhydration. That means you had a lot of water in the patient, but it is too much electrolytes, and especially old patients are not able to eliminate this through their kidneys. But if you let the patients drink, they only get water and they can refill the extracellular space with this. This is very pathophysiology, but this is the reason why IV fluids don't work in pathophysiology or in physiology. The second thing is just a pragmatical. Who should put in the IV cannula and who should put in the IV fluids? In countries where you run short of this, you have a really problem, or where you have no money, but even in very rich countries, you don't have the staff. You don't have the persons who can do all the work. And there was, I think in America, there was a shortage of these IV fluids a few years ago, and they started to let their patients drink because they didn't have anything. Any other possibilities, because they had not enough fluids to give them during their operation. So this is the main reason why IV fluids is not a good idea. They should just drink. And I forgot the second question.
It's what are the suggested clear fluids? And I personally would like to add, do they include things like broth and bouillon, or is it just sort of sugary drinks?
We reconfirmed the recommendation from the 2011 ESAI guideline, as well as the other guidelines, because it was too confusing to put other clear fluids on that. So this is water, this is tea, these are clear juice, pulpless juice. These are carbohydrated juice, or carbohydrated commercial or homemade lemonades. And this is coffee and tea with sugar, with honey, and with 1/5 small amounts of milk. You can use all these. If you have a bruise, it depends on what it is in. It has to be clear, not with any particles, and not too much fat, without fat. So I don't know. It's what is in a bruise exactly?
Yeah.
What are the ingredients of bruise exactly?
Well, I was thinking of bouillon cubes, where they just beef bouillon or chicken bouillon, which provides protein that the other drinks would not. And I was wondering if that was a good idea.
Yeah, but it's nothing you need just before an operation. You need protein before and after, but if you have protein within the few hours before an operation, there's not really a difference. It's much more important that they get the water or the fluids, the liquids, that they get the liquids, and that they get something which sets insulin production free. So that without insulin, the sugar cannot get into the cells. So you might have a high glucose measurement, but the cells are starving, because without insulin, the glucose is not possible to go inside. So these are the main two things. And I think if you make it too difficult, if you come with too many different things. There was another study, they had something you could eat, but in your gastric, it was liquid, something like that. So this worked pretty good, very, very, very good, but it's confusing because patients then think I can eat. So this is not a good deal. What you can easily do is give them water ice. Out of the ice, this is just frozen juice.
Okay, great. Thank you. And let's see. Yeah, so here's another question. Are any of the more liberal policies on preoperative fasting accompanied by solid evidence, such as gastric ultrasound to demonstrate low gastric volumes?
This is very, very important. Sorry that I go in. This is very, very important for emergency patients, because emergency patients normally don't have fasting rules. They didn't know that they come to the hospital. But in elective surgery, and for the question if patients drink clear fluids, we don't need it. It's just confusing. There was a very, very nice study. They educated a lot of doctors with a gastric ultrasound, a real good education. And all these doctors were were perfectly fine identifying patients who had something in their stomach, who had a full stomach. But for patients who had nothing in their stomach, the stomach was empty, they falsely decided that half of these patients would have a full stomach. So if you use ultrasound in elective surgery for patients who just had had something to drink, and they all have an empty stomach, the ultrasound might say it is full because it's very difficult to do this ultrasound if you are not used for it for many, many years, and you don't have ultrasound in many anesthesiological departments, or not enough to do this. So this is something for emergency, not for elective surgery, and this is what is also recommended by our consensus statement, Annemarie.
Great, thank you. Anne-Marie, you chair the Anesthesiologist Societies Committee in Europe, which brings together national anesthesia societies from all across Europe. From what everyone's been saying, one of the biggest barriers that they hear from colleagues is always, we'd love to change, but we're waiting for our national society to endorse it. So what do you think could realistically turn all these parallel national conversations into a shared European or even international global movement? What could patient organizations, nurses, clinicians do to help make that happen?
Thank you for the question. First of all, yes, on a local, national level, we are working on that. So I am the lead of the guideline, of this guideline in our hospital. In Malta, we are very lucky. For those who don't know, we're just a very, very small island with one main national hospital. So it's easier, I think, to bring about change, with proper education. As chair of the national societies, I have already been allowing different presidents of national societies to present interesting guidelines, interesting projects, so that we can all learn from each other. So this is one of my next steps. I think the problem that we saw from our study is that this problem is not all in Malta. It's European-wide, it's worldwide. And the problem, I believe, is not the evidence. We know we have a problem. We know that liquids are not a problem. The problem is the implementation. So I think if we can all learn from each other, and we can all learn how to implement, how to close this big gap, that would be a very good step forward. And I really intend to work on this. There is a lot of publications out there, more and more, about patient-centered care, patient-reported outcomes, having the patient at the center, really looking at the well-being, the anxiety, and I think we all need to be delivering the same message. We need to, I think, also involve patients a lot more. Like Anne Rugeberg did in our consensus statement. We have, unfortunately, very sad to say this, but we have left our patients out of many guidelines at national level, even at European level. And I think this is also a very important part to address. We have to deliver the same message consistently. One of the things I want to do is also on a local level, for example, is to go on national television, radio, as go speak to GPs. We all need to deliver the same consistent message.
Yeah, great. Thank you. And we have another question. It says, in undergoing liquid fasting before operation, what period should you eat? That is, when should you eat? How much should you eat? And when not to eat. So I think this is about really different kinds of meals. And secondly, it says, what kind of food should one eat after going through liquid fasting and surgery? So it's talking about starting up an intake again after surgery.
Yes, this is a very important question because for decades there was no distinguishment between liquids and solids. For solids, it's really, really important to have good fasting and long enough fasting times. If you are young and healthy, then 6 hours is fine for nearly every meal. But if you are old, if you have a diabetes, if you have gastroparesis, if you take GLP-1 receptor agonists and then eat a very heavy fatty meal and drink 3 glasses of red wine, it might take 8 to 12 hours to empty the stomach. So this is something you have to judge for each patient. What did they eat? What did they drink? And this is why we said in our consensus statement, clear, non-clear liquids, it's 6 hours always because they emptied faster from the stomach. But solid food, it's at least 6 hours. It might be longer, 8 hours or beyond this, if a patient has some conditions or if they ate a very heavy and fatty meal. And it is not possible to give for each patient something like a definite time. So in our fasting card project, we said the evening meal, it's okay, you can eat whatever you want, and then you can eat a light food until midnight, and then it's perfectly fine because during the night you should just sleep and don't have the stress from eating. And we are very, well, we have longer times in our fasting card project, a little bit longer than guideline recommendations, but we use it as a practical side of it. A colleague from mine said he had a patient who was very, very anxious about everything, and at 2 a.m. in the morning, he ordered some very big plate with fatty meat and everything and ate it, and was at 8 a.m. in the operations theater. And he really was thinking to say, no, I don't do the anesthesia because there will be something in the stomach. So you have to have a close look. And every thing what a patient is inconvenient about, you can give them clear liquids with carbohydrates. My husband had a coloscopy and he was very, very anxious that he will be hungry. And I said, there's no problem. You just drink lemonade. And he drank 5 liters of lemonade and there was no hunger. So you can do this in that way.
Okay, great.
I'd
Thank
like
you.
to add something if I may. So I completely agree with what Anne said, but unfortunately, I am not sure that all hospitals have moved away from that Mendelssohn 1946 era. You know, I am pretty sure that in many hospitals, patients are still being told just to be nil by mouth from midnight without the distinction between water and a large fatty meal. So this is a huge problem.
Oh, I think it's absolutely what people are being told all the time. Thank you. So Carmen, I want to ask you another nursing question. So you do a lot of training, quality improvement work for nurses and midwives and medical assistants. In the current training programs, yours and others that you're aware of, do these programs actually cover the harm caused by prolonged perioperative liquid fasting? Yeah, I mean the consequences for patients for over fasting, and if it's not covered, how can you start including it?
Yes, I assisted very, very nice conversation, and many information was giving here for our colleagues, and I'm very happy to have that information. And we all are agreed that continuing education are very important to promote that information and evidence to our nurses. But we notice already that the training often focus on the rule itself, but not enough on the patient experience and the harm created when the rule is applied too rigidly. in many training program, as Maria said already, surgical clinic nurses learn that the fasting is necessary before anesthesia and surgery. But the discussion is often technical about when we to stop food, when to stop liquids, and how prepare the patient. And already everybody knows that is that information that many hours, not 2 hours, is recommended. Is 6 or 8 hours often recommended the patient before the surgery. But it's we work now at national level at the curriculum for European founded program for anesthesiologist nurses, and realistic we can think to adopt a 4-step educational strategy. To include firstly fasting as patients like a safety topic in continuing professional education in this curriculum. After that, we thinking about use a short cases studies based on real clinical situation as nurses strongly identify with what they observe at the bedside. Third, provide nurses with the practical communication tool, for example, how knowing how to ask the doctors if the patient still required to fast, has the surgery time changed, or can we clarify the clear fluid are permitted. And the fourth steps, we're thinking to encourage hospital to review their local protocols in collaboration with anesthesiologists, surgeons, nurses, and patient representative. The key point for nurses to practice based on current best evidence and to encourage to act in accordance with the protocols. They should be equipped to ask the right question, to document discomfort of patient and participate in improving protocols. For my perspective, nursing education can be a bridge between evidence and daily practice. If the nurse understands the evidence and have institutional support, they can help change to culture in a safe and constructive way. I think nurses are very important in medical team because they are with patient 24 hours in every day, and I think promotes that evidence in nursing fields is very important.
Thank you so much, Carmen. And I'm afraid we have so many more questions in the queue, but we have run out of time. I'm afraid that is our last question. I'm going to turn it over now to Mirka Chikilova, the General Secretary of the European Patient Safety Foundation, to close us out. First of all, I want to thank all of our great panelists and our speaker and all of you for coming to our webinar. And now I'm going to hand it over to Mirka. So, Mirka.
Thank you very much, and it's a pleasure to have the possibility to conclude this very important discussion. And we have heard very clearly that this is a complex topic, and we need to look at all sides of the problem that exists, but has been until now probably, and not probably, it has been very invisible. And we need to keep in mind the real benefits that more flexible, clear liquid fasting will bring to patients, and also probably speak a bit more about the harm that is bringing when it's not respected. But at the same time, we need to understand the limits under which these systems are working and where the healthcare providers are, because there are protocols that are existing. We have heard about the guidelines, and the guidelines and protocols are there to safeguard the patient, but at the same time, they should be open to change and to adapt when there is such a strong evidence that when we are not moving, we are creating more harm. So I think today marks a very important moment, and not because everything that has been said or even less has been solved, but what we did today, we opened the conversation. We are making this issue visible, and we do it together with all stakeholders on board, with patients, with anesthesiologists, with nurses, with family doctors, and we do that in a transparent and honest way, because we are all aiming for the same goal. We want to secure the well-being and safety of the patient. So the dialogue that we have started today will continue, and that's the work that European Patient Safety Foundation will continue to do this and bring all stakeholders together to drive change and to support both patients and healthcare professionals, so that providing safe care becomes easier. I would like to thank very warmly to our speakers to be so honest and so engaged, especially Anne-Marie Camilleri and Anne Rugeberg, to drive this change and to really be the voice of those who understand that there is an evidence and there is a gap between this evidence and the implementation. Thank you also to all the other panelists and to you participants who join us from so many countries and so many backgrounds, to be here, to listen, to learn, and to start asking questions. We will need all of you to be able to bring the change and to make it a reality. And a very special thanks go to World Patient Alliance for co-hosting this webinar and for ensuring that we have had the possibility to meet and to discuss this important topic together. So thank you very much, and I'm looking forward to be with you all and continue discussing this important topic in the future. Thank you very much for your attention.
Thank you, Mirka, and thank you all for coming. And that concludes our webinar.
Thank you very much.
Thank you very much to all. A pleasure.
Thank you so
very
much
much.
for the invitation.
Bye.
Bye.
Thank you.
Thank
Bye-bye.
you. And this whole project lives that you go home and ask your anesthesiology list, why don't our patients drink?
Thank you.
Thank you.
Bye.
Bye bye.